So when patients are discharged from the hospital on prednisone or a steroid, their blood sugars can be in the 400s, 500s, undetectable on their reader, and they're just panicked. And often this leads to ER visits, rehospitalizations, a lot of distress for the patient.
You send somebody home with a glucose meter, but then the patient doesn't really know what to aim for or how many times to check a day. And the other thing is, a patient is sick while they're in the hospital. They may not have the mental capacity to absorb all of that information while they're also healing from an acute illness, getting antibiotics, trying to figure out all the other medications.
There's been multiple studies and guidelines that support that just early and structured outpatient follow-up, particularly post-hospitalization within 1 to 2 weeks, has shown to reduce rates of rehospitalizations, improve morbidity, and reduce mortalities.
Welcome back to Endocrine Matters. I'm your host, Dr. Arti Thangudu, and today's episode is extra special because I get to sit down with two of my favorite people. My teammates, my sounding boards, and my besties, Dr. Illuri and Dr. Mehta. These two women are not only brilliant endocrinologists, but also incredible moms who bring so much empathy, intelligence, and heart to every patient they care for. Dr. Illuri trained at Northwestern and Loyola and joined Complete Medicine to deliver thoughtful, holistic care. Dr. Mehta, who completed her fellowship at Baylor College of Medicine, shares that same patient-centered approach, taking the time to understand each person's story, lifestyle, and goals. One of the things I love most about working with them is how we constantly bounce ideas off of one another, challenge each other's thinking, and come up with truly personalized plans to help our patients thrive. And today, we're diving into a really important but often under-discussed topic, post-acute hyperglycemia. Those frustratingly high blood sugars that can happen after a hospitalization, surgery, or certain medications. We'll talk about why it happens, what to watch for, and most importantly, what we can do to make a big impact for our patients. So without further ado, let's dive right in. So to start off, what do we mean when we talk about post-acute hyperglycemia? What are we even talking about?
Yeah, so post-acute hyperglycemia is when there's high blood glucose levels that occur after the resolution of an acute illness or like a hospitalization. So, for example, if someone's been in the hospital and experienced an acute stress or illness, and then they leave the hospital, they may still have hyperglycemia that needs to be managed. So this could be pre-existing diabetes or new onset diabetes or stress-induced hyperglycemia. And usually the sugar levels or the glucose levels are above 140.
Yeah. Munira, do you have anything to add to that?
No, that's a big piece of what I was going to say, and I agree with everything Vidhya said.
Yeah, so settings like when people are on steroids for a reason unrelated to diabetes, that can bring blood sugar up. Chemotherapy, immunosuppressants, surgery, those things can cause the blood sugar to be really high acutely. And it can cause a lot of distress, and it actually can cause a lot of stress. So when patients are discharged from the hospital, let's say on prednisone or a steroid, their blood sugars can be in the 400s, 500s, undetectable on their reader, and they're just panicked. And often this leads to ER visits, rehospitalizations, a lot of distress for the patient. And it doesn't have to be this way. And so we kind of want to talk through those scenarios, what they look like, what the causes are, and what we can do about it and what we have done about it in the past. So let's talk about some of the common reasons that people have hyperglycemia after a hospitalization or after a major health event. First, let's talk about a really common one, steroids. When patients are on steroids, what happens with their blood sugar? Dr. Mehta, you want to take that one?
Yeah, in the setting of an acute illness or a stressor, steroids certainly causes this surge of glucose that typically occurs right after meals. And we see this quite prevalent post-meal hyperglycemia. There's this inflammatory response that kicks in. There's reduction of insulin sensitivity. The peripheral tissues are less likely to take up the glucose that the liver is putting out. There's glycogen stores that are getting depleted, and it's releasing all this glucose into the blood cells or into the bloodstream. And we aren't able to effectively take that back up into the peripheral tissue, so it stays high throughout your hospital stay. Particularly post meals, we'll see these surges in glucose levels, and there's insulin being thrown at the patient, but if it's not in the right ratio with the basal insulin and the prandial or pre-meal insulin, you will continue to see these surges, which translate to high blood sugars throughout the hospitalization. And then even when the patient gets discharged, because they get sent out on steroids and tapering doses of steroids, and there's variability and that's continues from day to day, week to week.
Yeah, and Dr. Illuri, will you talk to us about what specific situations might occur where patients are being sent out on steroids? And what are some of the names of the steroids that patients should look out for if they're on their discharge medication list?
Sure. So there's a lot of things that can happen in the hospital that would cause a patient to be discharged on steroids. And a lot of the times these steroids could be like prednisone. So folks can get discharged on prednisone tapers. Dexamethasone could be another one that folks are discharged on, especially with chemotherapy regimens. Hydrocortisone could be another steroid that patients could be discharged on. And these are all oral types of steroids. And all of these can increase blood sugars. So considering the different reasons, so sometimes if somebody's admitted with an infection, especially a lung infection or a COPD exacerbation, they can be discharged on steroids because of that. Sometimes people can get put on some kind of steroid taper like methylprednisone if they are showing up to the hospital or the ER with acute back pain. Other types of scenarios where patients are discharged on steroids is transplant. So if a patient has a transplant and they're either getting discharged after the first transplant, or if they have rejection, they can be discharged on really high dose steroids as well. And all these things can cause super high blood sugars after the hospitalization.
Yeah. And I think that leads us to segue into the next type of medication that can cause high blood sugars, which is immunosuppressive medications. Those can cause hyperglycemia by a different mechanism. Like we said, prednisone, a huge part of why steroids cause hyperglycemia is due to increased insulin resistance. So we see the blood sugars often highest after meals. Immunosuppressants work a little bit differently. Dr. Illuri, do you want to take it?
Sure. So some of these, specifically like the calcineurin inhibitors like tacrolimus and cyclosporine, they can affect the pancreas directly. So they can have a toxic effect on the beta cells of the pancreas. So when that happens, the pancreas is unable to secrete insulin as well. And sirolimus is another one that can reduce pancreatic beta cell insulin secretion. So those kind of have a different mechanism of action that can worsen glucose levels and can increase glucose levels. So a lot of these transplant patients have those types of immunosuppressants, plus they're on steroids. So the combination can be really tough for those patients, and you get a lot of hyperglycemia.
Yeah. So when we talk about beta cell destruction, beta cells are the cells in the pancreas that make insulin. So those are the cells that get destroyed in things like type 1 diabetes or autoimmune diabetes. So these are patients who it's not insulin resistance, it's not lifestyle related. It's just that their pancreas is no longer functioning to produce insulin, which is a hormone that pushes sugar into cells and helps the body use sugar properly. And so with some of these immunosuppressants, like Dr. Illuri mentioned, that we use in transplant patients, patients can have actually a more type 1-like picture. So we, as physicians, we need to be aware of this and watching out for it. But as patients too, who might be undergoing transplants, have family members who are on these immunosuppressant agents, if their blood sugars are getting really high, we may not be able to manage it with like our regular regimens of starting with orals first. We may have to go straight to insulin. And that's where we need to check things like pancreatic function, C-peptide, to see if the pancreas is producing insulin or not, so that we can correctly manage the high blood sugar. And then let's talk about kind of the last big thing that happens all the time in the hospital that patients can come out with hyperglycemia with, and that is surgery. Surgery itself can cause stress, which can cause hyperglycemia. Usually it's transient, but it can cause really, really, really high sugars that we need to manage carefully, because if we overshoot, if we kind of freak out about the blood sugar and give them too much insulin, for example, and then the surgical stress calms down in a couple of days and we don't change the regimen, that can cause hypoglycemia or low sugar, which can be really dangerous. Do either of you have anything that you want to add about post-surgical stress?
Yeah, I mean, I was just going to say briefly, like 30 to 80% of surgeries, you can see hyperglycemia. And we used to see this all the time in training where, these folks required an insulin drip a lot of the times, and it would rapidly decrease. So like post-op day 1, they may be requiring 30, 50 units of insulin, but by day 2 or 3, they don't need any. So when these folks are getting discharged, their insulin regimen changes so rapidly. If they're at home and nobody is helping them, they are at such high risk for low blood sugars when they leave the hospital.
Like if somebody has a cardiothoracic surgery or a CABG, like an open heart surgery, we often have a protocol of putting them on an insulin drip for this very reason, because the reason that high sugars are dangerous in the short term is they can impair healing and they can cause short-term issues. So we don't want patients to be severely hyperglycemic, especially in the setting of healing from a surgery. We want those wounds to heal nicely.
Yes, I agree. And I think the mechanism is, there's this stress-related hormone release that happens after surgery, and there's this surge in counter-regulatory hormones, glucagon, cortisol, and that causes this rise in blood sugar that we see decline gradually or rapidly, oftentimes, as the body naturally starts to heal from this stress and these hormone levels start to decrease. Another recent cause that we're seeing for this acute hyperglycemia is the use of immune therapy drugs in cancer patients, which also has this type 1 diabetes like effect, and these patients often present in DKA, very similar to the immunosuppressants that we were discussing earlier.
Yeah, that's super important, especially as these therapies become more used, more common, because sometimes patients go home and they're like, I never had diabetes before. Why is my blood sugar insane? And a lot of physicians don't know because some of the therapies are newer. And also a lot of this is done in endocrinology training, not in general medicine. And so their primary care doctor, while they're doing their very best, they might be at a loss. And so I kind of want to go deeper into that point. But, we talked about the science behind this, but let's talk about the patient perspective. Like what happens to these patients when they're discharged from the hospital? What happens at home? And then hopefully we can talk about how we might be able to make that experience better for them. And Dr. Illuri, I know you had a recent patient that we've cared for that ran into this particular situation of severe hyperglycemia. Tell us kind of, obviously we're not going to talk about specifics to that patient, but tell us kind of what happened, what the experience was, and then we can walk through how we managed it differently than what is traditionally done.
Yeah, definitely. So, we had a patient whose story was they had a elevated A1C of 7 or so before hospitalization. And was not on any diabetes medication prior to hospitalization. So didn't have any experience with checking blood sugars or administering insulin, anything like that. Went in and was hospitalized and diagnosed with an infection and was sent home with high dose steroids, so a high dose prednisone taper, starting at 40 milligrams of prednisone, which is quite a bit. So in the hospital, patient was also given high dose steroids and required quite a bit of insulin during the hospitalization to keep those blood sugars in the 100 range. And when the patient was discharged, wasn't really given any clear instructions on how to adjust the insulin based on what the steroid dose was or how to respond to high blood sugars. Unfortunately, the patient wasn't even sure what a normal blood sugar target was. So, you send somebody home with a glucose meter, but then the patient doesn't really know what to aim for or how many times to check a day or anything. And this is hard too, right? Because if you don't have like thorough diabetes education done during the inpatient stay, how can a patient learn all of this? And the other thing is, a patient is sick while they're in the hospital. They may not have the mental capacity to absorb all of that information while they're also healing from an acute illness, getting antibiotics, trying to figure out all the other medications. So essentially, this particular patient was discharged and was able to see their PCP within a couple days. But again, it was kind of a brief visit with the PCP and was given long-acting and short-acting insulin with kind of like an insulin sliding scale, and was sent home with that plus a glucose meter. So when we met this particular patient, the blood sugars were in the 600 range, kind of ranging from the 300 to 600 range on a long-acting insulin plus an insulin sliding scale with a glucose meter. In this case, we prescribed a few things for that patient. We prescribed the Freestyle Libre continuous glucose monitor, and we linked it to our clinic. And once we did that, I was able to review the blood sugars 24 hours a day. A continuous glucose monitor is able to generate a glucose value every 5 minutes. So we had a nice graph of what the glucoses were doing. And we also adjusted the insulin regimen. We added a medication called NPH on top of the long-acting insulin as well as the short-acting insulin. And we were able to review blood sugars multiple times a day and make adjustments to the insulin regimen. And even being an endocrinologist, it takes time. You can calculate the insulin doses, but you really have to see how the patient responds and make adjustments maybe 2 or 3 times a day, especially in the beginning, to get reasonable blood sugar control. So in this case, with that particular patient, the first week especially, we were communicating 2 or 3 times a day to make adjustments to the insulin dosing.
Yes. And, Dr. Illuri and I, we were kind of tag teaming this patient because I happen to know the patient. And so I was checking their CGM and I was like, hey, Dr. Illuri, what do you think of this? And, it really does take this, when a patient is so hyperglycemic, when their blood sugars are so high, it really takes looking at those sugars closely, kind of hour by hour, which is what we did in endocrinology training as endocrinology fellows for inpatient diabetes. We looked at the patient's blood sugar all day and were constantly kind of making adjustments because we were the ones consulted on the very complex diabetic patients, the cystic fibrosis-related diabetes, the patients who were post-op, the patients with immunosuppressants. And so I feel for that primary care doctor because this is not what they are meant to do, what they're trained to do. Of course, diabetes is everywhere and every doctor needs to know how to manage it to some degree. However, this level of insulin titration is really in the wheelhouse of an endocrinologist. This is what we are supposed to do. It's just difficult because access to an endocrinologist, especially in endocrinologist who is essentially going to look at your blood sugar every hour is really challenging to get for most people, which is one reason we wanted to have this episode so people can know that it is available out there to have somebody really closely looking at your blood sugars. It's just that people don't know how to get access to this or to get access to us, nor do surgeons, nor do oncologists, nor does anyone know that we can get this tight management as an outpatient, which means not in the hospital. It just takes kind of connecting the dots, because what happens is people have these high sugars, they freak out, they go to the ER, they get an injection of insulin or IV insulin, their blood sugar comes down as it's supposed to do with insulin, they go home, and the same thing happens again, and it's a vicious cycle where they're going to the hospital, they're completely distressed. They also are incurring costs of multiple ER visits, which are thousands of dollars a piece. And it's just this vicious cycle that we are really here to say it doesn't have to be this way. We can figure this out with patients and keep them at home and keep them safe in these acute or post-acute settings. Dr. Illuri mentioned something called an insulin sliding scale. I think it's important for us to kind of explain what an insulin sliding scale is. Dr. Mehta, do you want to talk about that?
Sure. This is a popular regimen patients get sent home on, and what it essentially means, it gives you a number and it tells you based on where your blood sugar is, you will give yourself this amount of insulin. Essentially what it's telling you is 1 unit of insulin will bring your blood sugar down by 50 points. For example, so if your blood sugar is between 200 and 250, you'll take 2 units of insulin. If it's between 250 and 300, you'll take 5 units of insulin. Usually it should be individualized per patient and not standardized, because it depends on how sensitive a patient is to insulin. So someone who's very sensitive to insulin may only need 1 unit of insulin. That'll bring their blood sugar down by 100 points, as opposed to someone who's resistant to insulin. They may need 1 unit of insulin to bring their blood sugar down by 25 points. And so this is called a sliding scale, and patients get sent home with a printed version of it, and then they're expected to follow it on discharge.
Yeah, so basically it's like it tells a patient, hey, your blood sugar is 200, take this many units. Your blood sugar is 300, take this many units. And oftentimes these are kind of slapped on to a patient, like not really thoughtfully delivered. And, I know in my internal medicine training, we didn't know like, oh, we'll put on low dose sliding scale for this patient. Oh, we'll put on moderate dose sliding scale for this patient. It's not really thought out how it should be. And like Dr. Mehta said, patients are widely variable in their insulin sensitivity, and that's how we need to be thinking about sliding scales and the sliding scales that we choose. And most patients will not do very well on a sliding scale only regimen. Sometimes in the hospital, if a patient has very low insulin needs, or maybe they don't need insulin at all, that's a good use of a sliding scale only regimen. But most patients should not be sent home on sliding scale only. That is not going to fix their problem, especially if they have any sort of significant hyperglycemia. A little rough rule of thumb that I use and I was taught in my fellowship is that if a patient is on 40 units or less of insulin, we should opt for a low dose sliding scale. That's like 1 unit if your blood sugar is 150 to 200 and up from there. And if the patient is on a total daily dose of insulin, that means total units of insulin during the day are 40 to 100. Moderate dose sliding scale, so instead of 1, you'd use 2 units, and up from there at intervals of 2, and then a high dose sliding scale if they're on more than 100 units per day. That's a rough estimate. It doesn't work for most patients, but it sure does work a lot better than kind of slapping a sliding scale without thinking about it. So if you're a provider listening to this, keep that in the back of your mind for your patients who might be more insulin resistant than needing just a low dose sliding scale if the low dose sliding scale isn't touching them. And of course, send us a message, find us. We'll be happy to help you walk through those challenging patients as well. one thing that I wanted to talk about a little bit more was that NPH and prednisone thing that Dr. Illuri sort of breezed over a bit for that particular patient. How beautiful was that to start the prednisone?
So it's really interesting. So endocrine pearl. So prednisone was what our patient was discharged on, and it has the worst hyperglycemia probably the first 12 hours that folks are on it. And NPH is actually a very old insulin. So it is not something we generally prescribe anymore because we have much better long-acting insulins that are really stable in how they can control the blood sugars, and they act for 24 hours. But what's interesting about NPH is it lasts 12 to 16 hours, and there is a peak, and it really matches the hyperglycemia that we get with prednisone really well. So the nice thing about NPH is you can give it right when the patient is taking prednisone. So just like match it up, and it can work really well to control the hyperglycemia that happens with prednisone, especially like Dr. Mehta was saying, after meals, that postprandial hyperglycemia, the NPH can match really well with it. And then the NPH will wear off when the prednisone wears off. And then many times you can stop the NPH when the patient is finished with their prednisone taper.
Yeah, it's so nice to see because NPH and prednisone have kind of a similar pharmacokinetic curve. So like, let's say the patient takes prednisone every morning at 9 a.m. Well, if we dose their NPH at that same time, it'll follow the curve of the prednisone to sort of balance out the blood sugars, the high blood sugars that occur from the prednisone. And it can make, patients are terrified to eat in these situations because the second they eat something when they're on prednisone or steroids, their blood sugars skyrocket. So this can really help them without causing the hypoglycemia or low blood sugars that might occur if we have an insulin that's working when the prednisone has already tapered off. So I love that little trick or endocrine pearl, whatever you want to call it. It's nice. I think we totally geek out over the blood sugars. I often tell my patients, I think I'm more excited about your blood sugar than you are. And they're like, no, doctor, I'm excited too. I'm glad it's perfect. But these little tricks really help us. And we won't get too much into detail in this episode, but we have tricks like that for like tube feeds, for TPN, things in the hospital that can get patients' blood sugars really high. We'll cover that in a different episode because that will take forever. But I think that using these tools and really leaning on endocrinologists in this setting of post-acute, post-discharge hyperglycemia can make a huge difference in a patient's life. We do have a lot of tools. We already talked about different insulin dosing strategies. What are some other tools that you guys find really helpful when patients are struggling with really high sugars that we're able to use in our clinic? Dr. Mehta, you want to take that one?
Yes, absolutely. I think CGMs, continuous glucose monitors, are excellent. They give us so much more data, and we love looking at data and trends and patterns, as particularly with safe glucose insulin management to avoid hypoglycemia. Just like we care about avoiding severe hyperglycemia, we also care about avoiding life-threatening hypoglycemia. And CGMs, or continuous glucose monitors, allow us to access patients' glucose data, 24/7. We can look at their patterns and adjust insulin doses, medication doses. In addition, insulin pumps are really helpful as well because you can do a lot more adjustments of their basal rate hour to hour, put them on various degrees, different types of carb ratio sensitivity factors based on when their steroid dosing is, or whether they're on chemotherapy, whether they're on their menstrual cycle. So many adjustments we can make on insulin pumps as well. And we know for a fact, there's been multiple studies and guidelines that support that just early and structured outpatient follow-up particularly post-hospitalization within 1 to 2 weeks has shown to reduce rates of rehospitalizations, improve morbidity, and reduce mortality. So keeping this in mind when we follow these patients up outpatient is so important to avoid rehospitalizations and improve their quality of life, reduce hospital costs, slow down delays in care, et cetera.
Yeah, and we use this term rehospitalization all the time, and I sometimes think there's a disconnect between what that actually means. So a rehospitalization is because you get sick again, right? It's because you get so sick again that you have to go back to the hospital. And so I think it's really important for us to, yes, rehospitalizations are bad for everybody, but they're especially bad for the patient because the patient is getting so sick right after they leave the hospital that they have to go back and go through all of that again. And we have tools where we can prevent that from happening. And the reason that blood sugar is important, of course, nobody likes to see a high blood sugar. It scares people, but it is important for healing. Your body can't heal from an illness if your blood sugar is super, super high. And the blood sugar being high can cause its own problems down the road. But in the short term, if you're healing from an infection, if you're healing from a surgery, if you're healing from an autoimmune flare, it's not going to happen if your blood sugar is really high. So I know we talk a lot about the numbers, but I want to stress the importance of it's more than just the numbers. It's what the numbers, the high blood sugars actually lead to that make it very important. And I think that these tools that we have in endocrinology clinics are so incredible. The technology has come so far, even from when we were in fellowship. The CGMs have become so much more available, so much better, so much smaller. And we can literally look at a patient's blood sugar in real time. Like I'm talking to you and looking at what your blood sugar is doing on my computer at the same exact time. And we can see patterns that have occurred over the past several days or weeks too, to really make specific changes for you. In the past, even in my internal medicine training, we were kind of guessing, right? Based on the patient's A1C, which is a 3-month average, about what to do with their insulin dosing. We're not guessing anymore. We're seeing it in real time. We're seeing what the changes that we make do in real time and making much more informed choices, which I think makes an endocrinologist much more relevant, right? Because we can do so much more. Dr. Illuri, will you talk about how maybe we can collaborate with our oncologist colleagues, our surgical colleagues, our colleagues, so that they know that they can lean on us?
Definitely. I mean, I think that we should work directly with inpatient oncologists, transplant surgeons, and hospitalists, like anyone who works in the hospital and even outpatient too. When any provider, any physician who's starting acute therapy that can increase blood sugars. And we should, and it's the way we communicate with our patients. People have our phone numbers. They can text us. It's not hard to reach us. And that's how we work with our fellow doctors who are taking care of our patients. We call, we text, we're available in our direct care practice. That's the whole point of it. And we are available for acute consults. So when these other inpatient doctors or, clinic doctors who know that their patients are going to have issues with blood sugars, we're here and we can help with that. We can get your patient on a continuous glucose monitor. We can order insulin to their local pharmacies, and we can teach those patients how to deliver insulin and interpret their continuous glucose monitor data, and all the while communicate with the primary doctor on the case and communicate with the patients. And we love to do that.
First of all, if you're a doctor and you want our cell phone number, send me a DM. we will give you our cell phone number. I think right now the system is so fragmented, right? Doctors don't know that they can call each other. And when we do try to call each other's offices, especially in these big health systems, trying to find another doctor is impossible, basically. So I think we as physicians, we need to be working as colleagues, giving each other our cell phone numbers, being open to that, because it makes such a tremendous difference in the lives of a patient. Like yesterday, we had a close friend with an emergent issue, called my ENT friend, got the friend in that same day, fixed the problem. Doctor to doctor communication. We're both in private practice, so it makes it a lot easier for us to get patients in onto our schedule because we're in control of our schedule. This is, you guys will hear me say this over and over again, but doctors being in control of how long we spend with patients, how we can get patients into our clinic is so important, because we are acutely immersed in why it's important. When we put all these barriers, especially in big health system type practices, to even get in, or restrictions on who can get into our clinic that the doctors have no control over, it becomes very difficult to take care of patients and do the right thing for our patients. So this is why you'll hear me say over and over again, being your own boss, not being employed by a big system. That is how you maintain control over the care that you deliver as a physician. And as a patient, when your doctor is in their own private practice versus part of a big health system, that doctor is going to be able to have a lot more control over the care they deliver for you. And as long as that doctor wants to deliver the level of care that you deserve, that's what you're going to get if the doctor is running the show. That's really, really important as we move to like 70% of physicians are now employed. That means doctors are losing control, and therefore patients are not going to get doctor-directed care. They're going to be getting system-directed care, and systems are driven by profits over patients. So I do think what Dr. Illuri said about collaborating with the oncologists and rheumatologists and all of the other prescribers is super important. And I think that perhaps starting the plan early, right? Like identifying, okay, this patient is probably going to go home on steroids, whether you're a family member of the patient themselves. It's hard when you're a patient when you're sick to be making decisions, but family members certainly can start planning for the discharge. The doctors should be planning for the discharge. That's a good time to think, okay, this patient is going to go home on steroids, or they're having a lot of hyperglycemia in the hospital. Let's get them into endocrine quickly. That is a hard thing to do in the traditional setting, but that's why we exist in direct care, to get patients in quickly. We'll get a patient in same week, same day if needed, to ensure that the patients are given the care that they need in the time frame that they need. We'll have another episode, which I'll link in the show notes, about what direct care is, because that's a whole episode in itself. But there are endocrinologists like us who we live and die for blood sugar. Like, we want to do this. We want the patients to call us and text us, and we want the opportunity to help you guys and your patients and your families figure out how to make it work in this crazy healthcare system that we live in. And we want your blood sugar to be the least of your worries. That's our goal. Dr. Illuri and Dr. Mehta, do you guys have anything to add to that?
No, I feel this way, especially since, being able to provide this level of care, this quality of care. We also have a wonderful diabetes educator and a dietitian, nutritionist on our team. And that's important to us because we know that that lifestyle and diet is such an important piece to blood sugar management, glucose management, and that providing comprehensive multidisciplinary care is a big piece of effective diabetes management. And things change quickly in the post-acute state. Once you're discharged, activity level changes, diet changes, medications are changing. And so having access to us and being able to do this, make these changes on a daily basis is so important when you get discharged.
And also, it's a convenient way for patients to have care. I think a lot of the times, especially transplant patients or post-surgical patients, they have a lot of appointments that they have to keep to check on their wounds, to check on their immunosuppressants. They have to go to the lab multiple times to check, their immunosuppressant levels and their kidney function. So being able to communicate with their endocrinologist to manage their blood sugars from home is so valuable because they can contact us before their lunch. Like, if I'm going to eat lunch right now. What am I supposed to give? My blood sugar is 250, and it's just so convenient that we can look at their blood sugars while they're at home and be able to give instructions on dosing and what they're eating and, fluid intake, all of this. So it's just another part of care that we can deliver in a convenient way for the patient so they don't have to go to another clinic on top of everything else that they have to do.
And there have been studies that have shown, to speak to Vidya's point, is that telemedicine virtual interventions are just as effective for glycemic control, for improving access, reducing costs, and supporting transitions of care. So I'm glad you brought that up because it's true, and we're able to provide that.
Yeah, telemedicine is so powerful in this space because access to diabetes care in general is really challenging, and in this post-acute setting, it is even more challenging. And I think a big gap that we are beating over you guys' head is that this type of care exists, and we're here to provide it. We're not the only direct care endocrinologists either. And so if you know that you're having trouble with high blood sugars, whether it's post-acute or not, there are doctors like us who will work with you minute by minute, hour by hour to get those blood sugars down, and we're happy to do it. And we will, if you are a physician and you have a patient with hyperglycemia, just give us a call. We'll give you guidance whether or not we see the patient or not. They don't necessarily have to come into our clinic, or let's say they're in a different state where we're not licensed. We are happy to help give you some of the tools that we have to help the patients bring their blood sugars down, stay out of the hospital, stay home comfortable with their families, all of those things. So any final words before we let everyone go today?
I think the other thing is just education for these patients is really important, as well as providing the tools for success. So it's just think about a patient who's in an acute hospitalization. There's so many things going on. How can they learn everything there is to know about managing diabetes? So it's just these frequent touch points and frequent reminders are so useful from an endocrinologist as well as a diabetes educator, which most of these endocrinology direct practices have now. So, it's just frequent time points, I think, for post-acute hyperglycemia is so important, and it's so important to provide that for these patients.
Yes. And if you're a patient out there listening, you deserve this type of care. You deserve care where you feel heard, supportive, you have access to your doctor. This is how we actually make people healthier, happier, more productive, live the lives that they want to live. And the care does exist. We're trying to grow this movement so it can exist for more patients. But you deserve really, really good care. And if you don't feel like that's what you're getting, seek other options, look for other options because it exists, and we want to connect the dots for you. Munira, did you have any last thoughts before we let everyone go?
So I do think education is a huge part of it, and empowerment, empowering your patients to believe in themselves and gaining confidence in their ability to take care of their blood sugars, and building trust in themselves and us as their care team. It just overall improving their experience and their ability to manage their diabetes is so important. And I think we all believe that's important, and we incorporate that in our practice on a daily basis.
Yes, absolutely. Well, thanks so much for listening, everyone. Thanks, Dr. Illuri. Thanks, Dr. Mehta, for being here. These women are the best, and I'm so lucky to have them in my life and so proud to share them with you guys today. If you guys want to learn more about us, you can visit our practice website. It's sacomplete.com. If you'd like to make an appointment, you can find more information there as well, or follow along with me at Dr. Arti Thangudu on Instagram, YouTube, all of the platforms.